Welcome, everyone. Today I'll discuss how to optimize surgical coaching through participating surgeons' feedback. My name is Jason Pradarelli. I'm a general surgery resident at the Brigham and Women's Hospital, and I did this research as a safe surgery fellow at Ariadne Labs in Boston. My disclosures are research grants for my fellowship and my position as a medical director at the Academy for Surgical Coaching, a nonprofit organization. Peer surgical coaching is a partnership between a surgeon and a coach, where the coach empowers the surgeon to improve their performance through a series of longitudinal one-on-one reflections on their own practice. Pilot studies have shown that surgical coaching is feasible among surgeons in practice and has high perceived value. However, several barriers have been identified to implementing surgical coaching widely, notably cultural resistance from surgeons. It remains unclear how to implement coaching programs in a way that surgeons will buy into it. To be adopted widely, coaching must integrate with surgical culture and address surgeons' concerns, particularly important concerns about maintaining an authoritative image and a fear that surgeons will lose autonomy if they have a coach. In this qualitative analysis of a new surgical coaching program, we aim to identify implementation recommendations from surgeons' exit interviews and ratings of their own coaching interactions. The study evaluated the Surgical Coaching for Operative Performance Enhancement, or SCOPE program, a professional development initiative for 46 practicing surgeons at 4 academic medical centers in Boston. One faculty surgeon at each institution was invited to be a coaching champion and recruited participants from a variety of specialties, including general surgery, neurosurgery, orthopedics, thoracic, urology, and vascular surgery. Surgeons were assigned to one coaching role, either coach or coachee, by the local champion and were paired one-to-one for the duration of the program. Matching process was not standardized in this study. 2 champions asked their surgeons whether they preferred to be a coach or coachee and with whom they'd like to be matched, and the other 2 champions relied on their familiarity with each of the surgeons and assigned pairs based on seniority, specialty alignment, and compatible personalities. All coaches and coachees attended a 3-hour in-person training at the start of the program to learn the core principles and key skills of surgical coaching, and also to normalize the process for all participants. Coaching pairs followed a defined structure of preoperative goal setting, intraoperative observation by the coach, and postoperative debriefing. We intended for each pair to do 3 sessions throughout the program. We provided language for surgeons to focus their coaching sessions on, including technical, non-technical, and intraoperative teaching skills. Upon program completion, surgeons were interviewed one-on-one to understand their experiences as a participant and to get their recommendations for implementing surgical coaching. Questions were grouped for thematic analysis into the 3 domains listed here. Thematic saturation was reached with 5 pairs of coaches and coachees in this study. Within 24 hours after each session, we asked each coach and coachee to rate their coaching session using the Net Promoter Score, which asks how likely someone is to recommend that coaching session to a friend or colleague. Net Promoter is used frequently in business to measure customer experience and predict the growth of a company. For the Net Promoter Score, 9s and 10s are considered promoters, 7s and 8s are passives, and 0 through 6s are detractors of the product, brand, or company. To interpret surgeons' recommendations for surgical coaching in the appropriate context, we stratified their interview responses by the Net Promoter Score category. Of the 46 surgeons, nearly half completed all 3 coaching sessions as recommended. 87% completed at least 1 coaching session with their assigned partner. The study had a notable gender imbalance with 4 times as many male surgeons participating as female surgeons. However, surgeons came from all levels of clinical experience and at least 13 different subspecialties. Across Net Promoter Score categories, there were no systematic differences in surgeons' demographics, including the number of coaching sessions completed. Promoters were as equally likely as detractors were to complete all 3 sessions. For how participants described the coaching experience, key themes included the impact of the first session, the perception that coaching quality improved, and that coaching interactions became more comfortable over time. Despite agreement on these findings across Net Promoter Score categories, these themes differed in how promoters actually experienced their coaching sessions compared to how detractors experienced theirs. For example, promoters tended to have excellent first sessions, which might have led them to trust the coaching process more and rate their session highly. Detractors who rated their sessions less favorably described suboptimal first sessions, even though they felt they got better at coaching in subsequent sessions. All surgeons agreed that the most important characteristics for a productive coach-coachee relationship were mutual respect and trust. Where promoters and detractors differed in their experience was in having transparency about each surgeon's intentions and established rapport before any coaching activity began. Promoters reported a clear understanding of each other's intentions and had already established good rapport with their coaching partner before the program began. In contrast, detractors described a lack of transparency or pre-existing rapport. Participants agreed that surgeons should be matched so that the coach's strengths complement the coachee's goals. And in this study, the interactions were more valuable when the coach and coachee were in similar clinical specialties. Notably, detractors acknowledged either not setting goals at all or not having their debriefs stayed focused on their intended goals. Another important theme was that the coachee's preferences should be solicited when the coaches are selected in the first place. Beyond the one-on-one coach-coachee relationships, important facilitators for surgical coaching included selecting cases for observation that were tailored to the coachee's learning goals and also having the buy-in of the local work environment. This buy-in of the local environment was an important theme for both facilitators and barriers to surgical coaching. While OR staff welcomed the presence of a coach during promoters' cases, some detractors conveyed a stigma associated with surgeons having a coach, reporting comments from OR staff that some surgeons needing a coach must be bad surgeons. Promoters referenced their training material from the training workshop, whereas detractors were more likely to say they forgot that material. Lack of protected time and scheduling challenges were barriers for all participants. So overall, we recommend that coaching programs set the right expectations for individual surgeons' experiences, especially for that first session. Programs should optimize the coach-coachee matching process by aligning the coachee's goals and specialty with that of the coach. Programs can also facilitate productive sessions by creating a local environment that invites surgical coaching. There were several limitations to this analysis, including wide heterogeneity of the surgical specialties involved, selection bias of volunteer participants, and underrepresentation of female surgeons, and administration of the Net Promoter Score immediately after each session, rather than after the full program, when surgeons will have had more time to reflect on its longer-term impact. Understanding how and why surgeons rated their own coaching sessions in this study, we directly investigated key cultural barriers to surgical coaching. Importantly, surgeons who participated in coaching agreed on key implementation recommendations for surgical coaching programs. These recommendations' validity was strengthened by their association with the ratings that surgeons gave their own coaching sessions. With empirical implementation evidence, we hope to assist organizations in establishing effective surgical coaching programs that enable meaningful professional development for surgeons and ultimately enhance patient care. Thank you for tuning into this talk today.